Hello, my name's Simon Hayward and welcome to this Blackpool Teaching Hospital video lecture on lung ultrasound. Today I'm going to be talking through how to get the best image acquisition by using the optimal settings and processes with your machine and your technique. I'm running through what I call the 4 Ps: position, probe, picture and protocol. So we'll dive into what each of these mean now. First of all, position. You may be scanning for a couple of minutes or a little bit longer. So one of the most important things is to make sure that your patient and you as the clinician and the scanning person is comfortable. There's nothing worse than getting into an awkward position and trying to hold that for a good few minutes, particularly if you start to get uncomfortable. And the same with the patient. So do bear that in mind before you even start. Have a little bit of a plan about how you might go ahead with the process. Think about where you're going to be scanning. So with lung ultrasound, you're pretty much set on 6 places on the patient's body, more if you're going to do a lung ultrasound score. So again, bear that in mind. Think where you might be on the patient's body and set yourself up accordingly. One important thing to make sure that you're not twisting your body too much or holding a position for too long is the line of view with the machine. If possible, make sure that you are scanning comfortably so that you're in a standing position directly in front of you as the machine screen. So you're not twisting and turning while leaning over a patient on the bed, trying to get a good image while also twisting to look at the screen of the machine. But the whole time, do maintain the patient's dignity and keep them comfortable as much as possible. Surface items, clothing, dressing, wounds, ECG dots, things like that, they can really mess up your images. So make sure before you even start that you can get access to the correct sections of the patient's thorax without having to do too much movement. So with the gel, you can certainly have too little gel. Very rare to have too much, but make sure you've got enough to get a good image that you need. Usually what happens when you don't have enough gel is that the image on the screen gets quite dark. The more gel you have, the less air between the probe surface and the patient's skin, which means your image is as good as it can be. I mentioned clothing, dressings and ECG dots. So what tends to happen, either the person scanning lifts the probe away from the skin on one side of the probe, and you get this dropout from the image here. That means that either you've lifted that side of the probe, or you've started to go over the patient's clothing, their gown, onto a dressing, onto something like an ECG dot, which doesn't allow the ultrasound to penetrate at all. So do bear that in mind if you start to see this sort of image on your ultrasound machine, that actually you're missing a third, if not half of your view, and change your position or the patient accordingly. And finally, do bear in mind the position of the patient with regards to the pathology you may or may not be scanning. So what do I mean by that? As the pathologies move within the patient's body, depending on how you position them, you will scan in different positions and expect to see different pathologies in different areas of the thorax. So in this example, we have air and fluid in a bottle. And as you start to recline the patient, go from sitting to reclined, the pathology will move accordingly. So do bear that in mind. To get good images, you need to be aware that your pathology may move around within the thorax depending on what you're trying to scan. Secondly, probe and the probe of choice. So you have 3 choices: curvilinear, also known as the abdominal, the linear, or the phased array probe, which is also known as the cardiac. Each one has their benefits, and some of these are listed on the screen here. You can choose whichever one you want to scan the lungs. My personal preference is the curvilinear or the linear because of their decent sized footprint to view the pleura. And then the curvilinear can certainly do a little bit more of the deeper imaging into the towards the mediastinum, particularly in the posterior lateral areas of the lung. There is a little bit of a trade-off and compromise. So the higher frequency probes give you a really clear image, but they don't penetrate quite as far into the tissue. So this would be the linear probe. Really good for superficial structures, not so good for the deeper imaging around the posterior lateral and near the diaphragm. Lower frequency probes give you a lower resolution image, so it's not quite as clear a picture, but they do allow you to penetrate further into the tissue so you can see deeper into the thorax in that posterior lateral area. And these would be the curvilinear, also known as the abdominal, or the phased array, known as the cardiac probe. There is an orientation and probe marker on every transducer probe. These can be found on the side, and they should correlate and line up with the image on the screen, so you know which side of the patient and the probe you are scanning in what orientation. There's a standard method to keep this consistent, particularly when you're scanning or when you're trying to record images for somebody else to view, so that they know where you are scanning with regards to the patient's anatomy. Another bit of advice is to hold the probe like a pencil. It stabilizes and gives you the most control and fine movement control when you're trying to scan very subtle changes during a scanning session. To stabilize your hand further, you can ask your patient for permission, if needed, to rest your hypothenar eminence, so the border of your hand by your little finger, against the patient's body, just to stabilize the scanning hand so that any movements you do with the probe are a lot more secure. Another technique is to use a little finger. Just have that resting on the patient's skin so that you can again stabilize that probe. Otherwise, with the contact gel sliding around, you may find that your probe slides all the way across the patient's body without you even realizing it. Next, some of the probes have buttons on them, and if you program these buttons in a certain way, they can help you stop needing to move the probe or move yourself or to reach across to the machine. So at the moment we have a machine that has them on the linear probe, and I have set them for presets to enable you to freeze the image, and one of the more important things, to store an image. So you can press one of the buttons that has been preset to that, and you can actually take a video clip without having to reach across to the machine. Again, this just allows you a little bit more comfort, a little quicker, and it means you don't have to twist and turn to reach the machine if it's just slightly out of reach or across the bed from you. Within ultrasound scanning, we can certainly standardize some of the movements and some of the descriptions of the movements we talk about. This is more useful when we're teaching, peer learning, things like that. So at Blackpool, we're going to try and talk about these particular movements. So we talk about sliding. So this will slide along the small edge of the probe from side to side. We can talk about rocking in that same orientation. And we can talk about sweeping along the larger face of the probe. So slide and sweep are the same movements, just in different planes of the ultrasound probe. Keeping the probe static on the surface of the skin, you can fan through the tissue. So you can talk about fanning the tail from front to back, but the actual surface of the probe stays still on the patient's skin. Pressure or compression. This can be useful, particularly if the image isn't quite so clear, just a little bit more pushing into the patient's skin. Again, be aware of comfort with that. Make sure you're not pressing too firmly on the patient and get their feedback. And then rotating, so you're just keeping the probe still on the surface of the skin, and you're rotating through the center of the probe just to turn that probe slightly. Okay, P3, moving on to picture. So we have different modes on an ultrasound machine. We have the B mode and the M mode. They should be familiar to you from learning ultrasound, but you can certainly move between these two modes to get some of the image quality and the type of images that you want. B mode is the most common and used the most often. Majority of imaging for lung ultrasound will be done in B mode. If you're looking for some very fine movements, like lung sliding, then you can certainly use the M mode setting to view that lung sliding and hopefully get that seashore sign. So next we have the machine's presets. So these will be examples like abdomen, MSK, vascular, things like that. Many machines these days have lung presets. Now most ultrasound machines spend a bit of energy trying to remove artifacts from their images. They have filters and they change the harmonics of the machine and the image generation by removing artifacts. But when we're talking about lung ultrasound, we don't want them to do that at all. We want to see the A lines, we want to see the B lines if they're there. So where possible, use a lung preset because it allows the maximum visualization of these artifacts. And if they're there, you want to know that they're there because that's how you're going to interpret them. If, when it comes to the posterior lateral area, particularly, you start to see consolidation or effusion, then the machine can be switched over to those settings or even the abdominal setting so that you can actually get something that resembles more of a true image under ultrasound. So you can play with the presets just to make sure you get the most and the maximum information out of those settings. We then go on to gain. So this is in effect the strength of the signal coming back from the ultrasound machine and the machine's interpretation of that strength of signal. And it dials up the strength. So it's almost like brightness to some extent. So you don't want the image too dark, so the gain is too low. You want to try and get it in a middle setting so that you can see all the structures that you want, and you want to avoid trying to have the gain too high because a lot of the signal is too strong and you can't interpret the images quite as well. So here we have an image that's too dark, one that's about right, one that is too high with the gain setting. If you want to view very subtle lung sliding, you can turn the gain down on an image to make sure that you have actually got that glistening lung sliding motion of the pleura. So on the left we have something that's round about average gain, and on the right we have an image that as the gain has turned down, so you can actually use a slightly darker image, particularly when you're trying to visualize the pleura. And I hope that you can see lung sliding on both images, but particularly the one on the right, you just have that glistening stands out a little bit more. Next, we have depth. So this is making the machine not work too hard to give you the image that you want. Let it spend most of its time and processing power giving you an image that you want to interpret. So if you're looking for the whole liver with the diaphragm, for example, you don't want it too shallow. You can see lovely lung sliding and diaphragm movement on here, but you're missing half the diaphragm or potentially missing pathology that's further down. In the middle, you've got most of the diaphragm all the way down towards the mediastinum. You can see that movement and hopefully you'll have less chance of missing any pathology deeper into the body. But then again, you don't want to go too deep, where you can see this section at the bottom of the image on the right. It's scanning nothing, it's just an image that isn't optimized, and you're wasting the processing power of the machine by making it trying to work and interpret what's much, much deeper to the body on the image. Next, we have focus. Most of the modern machines tend not to need too much in the way of focus. They will try and give you most of the image on the screen in as sharp a focus as they possibly can. And acoustic windows. So this is your ability to trying to avoid things like bone. Bone will stop the ultrasound penetrating. It's your ability to view the lung through other structures, so like the liver or the spleen. You can actually look deeper into the body if you scan through a solid organ like the liver or the spleen. So one example of this is with these tight rib shadows that you can see on the screen. All you do is rotate the probe so that you can get that image between the ribs. So initially you can see 3 tight rib shadows, rotating the probe slightly more parallel with the ribs, and it just opens up the image, and then underneath you can see the diaphragm with the spleen and the lung as well. Okay, finally P4, protocols. Most of FUSIC, programmed from the Intensive Care Society, as well as FAMOUS and Cactus, talk about scanning 6 locations on the thorax, so 3 each side. This is something that is done in a very timely fashion. So if the patient is in acute respiratory failure, then scanning 3 locations each side to make a total of 6 means that you get a lot of information in a very short space of time, particularly if the patient is struggling and it's a time-limited situation. However, if you have a bit more time, the patient is stable, then you can scan 6 locations on each side, making 12 in total across the whole thorax. This is a way that you can then start to score each of these 12 locations from a score from 0 to 3. And you start to come with a semi-quantitative method of judging how aerated the lung tissue is. And this is something I talk about in another video lecture, so check that one out. It is important that the process you go through of saving images within the governance remit of your place of work. These images for training purposes, so you can get feedback on your skills from a mentor or a supervisor. It's also really good practice to audit your images regularly, make sure that you're keeping up with the highest standards to maintain a degree of quality assurance. So getting that feedback process, letting other people view your images, even once you're qualified and a mentor or supervisor yourself, having somebody that you can go to see if there's anything else that you can improve to improve your performance, your image acquisition. Definitely make sure that there's no phantom scanning. Report everything that you've done in the notes, even if it's just a training scan. So keep that quality assurance level high. Okay, image acquisition optimization. So in summary, again, the 4 Ps, positioning of the patient and yourself, probe of choice and how to use that to its maximum ability, how to tweak the picture as much as possible, and then the protocols that you use to try and get the images that you really need. Thank you for listening, and please look out for further videos in the series.